Chapter 46. And in Chapter 46, we'll take a look at patients with special challenges. So this is going to include people who have some either a developmental disability, potentially a physical challenge, or even people who are at home on some long-term medical care, possibly under the services of either hospice or home health. As with this chapter and all other chapters, if you have not read and studied the chapter on your own, please do so at your earliest convenience. Simply listening and watching the lecture is no replacement for actually studying it on your own. We continue again with the same sort of concept that the advanced EMT applies fundamental knowledge of growth, development, aging, and assessment findings to provide basic and selected advanced emergency care and transportation for a patient with special needs. There is a multimedia video on autism that you can look at on the non-narrated PowerPoint. And our objectives. There's not a lot of objectives yet. The objectives that we have apply to multiple different types in cases. So the objectives you'll find on pages 10, 15, and 16 in your textbook. All right, so more so today probably than any other time, we have more and more patients that we're encountering with special challenges, whether they be things physically such as obesity or paralysis, maybe they're sensory issues such as inability to see or hear, or perhaps they're on certain medical requirements that these people need on a regular basis, or different social conditions. And the patients with these challenges are in a variety of settings, whether we're seeing them in nursing homes, we're seeing them in home health, maybe we're seeing in some sort of assisted living, special schools, and so on and so forth. So it's important for us to be empathetic to the patient's condition and not judgmental. I think that's human nature almost for us sometimes to be a bit judgmental of those things that we don't understand. To be empathetic isn't saying that I understand where you are, but it's to understand that they have a difficulty or they have a difference, and understanding that their life is different than everybody else's, and everybody has this same. Everybody has different challenges in their life. It just depends on the hand that you're dealt. Care for our patient regardless of their history, mental state, physical state, living conditions, and that the patient and their family members are the most reliable source of information about a condition or disability. If I'm teaching a class and I find out somebody in the class is either a patient with or parent of a patient or caregiver of a patient with a certain condition, I oftentimes will ask them to pipe up during part of the class, because I can study it all I want in the textbooks, and I can read 100 different articles on it, and I can take college classes on it, but until I have lived it, I'm never going to know it as well as they do. I might have one perspective on it, they have yet another perspective of somebody who has to live day to day with it. And so I encourage you, as you find people in your community or your service area, take the time to talk to them and find out more about that patient's condition. It's just something I find completely fascinating when people can share with me a little bit about their condition. Sometimes when you're transporting a patient, you may have a long transport time, and you may have to, you may not be doing constant stuff all the time, like vitals or adjusting IVs or whatever. Take the opportunity to learn. Take the opportunity with your patient to get more information on their life. That goes with your case study. So sensory and speech impairments. With the hearing impaired or the deaf patients, you are going to have people who maybe have a partial loss of hearing in one or both ears. They may have been deaf from birth. They may have slowly lost their hearing as time's gone on. You may have people who just have some difficulties. So Iowa Western was a good resource when I was there full-time for this sort of thing, because the Iowa School for the Deaf is in Council Bluffs, and Iowa Western Community College has a sign language interpreting program. So, you know, there's opportunities there, and there's people in the Council Bluffs area that you can learn more about the hearing impairment. They often will rely on hearing aids. They may also read lips. People that are completely deaf, hearing aids are probably not going to assist them. And depending on the type of hearing loss they have, they may be using something called a cochlear implant. And a cochlear implant is actually something that's implanted in the bones of the skull right next to the ear. And it's basically a little amplifier that is put into, worked into their hearing system. There's usually a little external appliance, kind of is kind of a disc shape that is placed usually right behind the ear, and it attaches actually with a magnet to the internal stuff, and it works to help amplify some of that the speech and sounds, so they are able to at least hear some things. It may be necessary to speak louder, but not shouting. Raising your voice a little bit may help them. Maybe speaking a little slower than you normally do may help them. That'll definitely let them see your face in case they are able to read lips. In sign language, if you know sign language, great. Knowing that American Sign Language, people who routinely use American Sign Language are very fast, they're very good. And most of us that don't use sign language on a regular basis, we could probably make out the letters with our hands, but it could be very difficult for us to keep up with a patient who regularly uses sign language. Don't forget, there's always the possibility of handing them a pen and a piece of paper and having them write out what they're trying to tell you. And they're probably easier to deal with that disability than some of the other ones, such as vision impairment. Blindness. Now, loss of vision in one eye or both eyes in specific parts of the visual field. Sometimes people have no peripheral vision. Sometimes people have difficulty seeing at night. I grew up in Nebraska City, which is the home for the Nebraska School for the Visually Impaired. So I knew many people who were visually impaired. And it's amazing how well they cope. These can be congenital issues, can be a result of illness or infection, injuries, degenerative conditions involving the eye, the optic nerve, the brain. You can develop things. You can have something called a macular degeneration, in which parts in the central parts of your vision start to degenerate. Glaucoma can affect your peripheral vision. Cataracts kind of covers over the eye there. We've talked about that in geriatrics. You can have a retinal detachment, in which the retina is the part that has the true sensory cells in it that are detecting what we're seeing. And those sensory cells start to detach from their base layer in the eye. And therefore, it takes away the vision. Of course, you can get all kinds of things, such as a bleed around an optic nerve or a tumor on an optic nerve, which is going to create a major issue. And there's tons of things that get into eyes. Eyes are so delicate. You know, once we have the opportunity to try to save an eye, that's a major thing, because they don't do well. They don't bounce back well. Eyes just are so delicate. And understanding that we may have service animals. In many cases it's a dog, but when you have a service animal, do not attempt to pet the dog. The dog is specially trained when they go to work. They are in complete work mode. They are not in play mode. So it may be necessary to transport that animal with the patient. And if you try to separate the animal from the patient, things could get very ugly very quickly. So it is an ADA thing that if there's a service animal present with your patient, that you have to make reasonable accommodations to take that service animal along. Speech impairment. It's kind of like been me for the last couple of days. A language disorder, where the inability to understand spoken or written communication, or specifically my issue, articulation, inability to speak clearly. So dysarthria is a difficulty speaking clearly. So we may not be able to fully comprehend things, or maybe we're able to comprehend them, but it's not something that we can make other people aware of that we can comprehend. And sometimes, particularly we'll say patients that have suffered head injuries or strokes, they can actually understand what you're trying to tell them, but they have an inability to form the correct words and or sentence strings to allow us to have a conversation with them. So it makes it look like they actually are disoriented to their surroundings, when in all reality they just simply can't get the message out that they're trying to. And it is very, very, very frustrating to those people. We can have voice production disorders. And that voice production disorder is an impairment of the normal voice, or hoarseness or unusual pitch results, where this could be a problem with some paralysis of nerves or muscles that actually produce the voice. Fluency disorders such as stuttering. I think most of us have known stuttering people before. I can recall in paramedic school riding with a paramedic preceptor who had a terrible, terrible stutter when he was, we'll say, off. So when we were in downtime, he stuttered very, very, I guess that's a Freudian slip there, myself stuttering. He stuttered terribly when we were around the station or whatever, but once he would get on a call and kind of get his mind engaged, the stuttering went away. It was pretty amazing to kind of to pay attention to that. So when he was really in, the stutter went away. And then sensory impairments involving multiple patient senses. So, you know, take Helen Keller, for example, being blind and deaf. And in a sense was considered mute, although she was eventually able to talk. But being blind and deaf, and what a severe disadvantage that would put you at. So it can make difficult the process of communicating to the patient what exactly we're trying to do. So, you know, imagine if you needed to do a 12 lead on somebody who was blind and deaf. How are you going to tell them, I'm going to take your shirt off and put stickers on your chest to check your heart? That could be so scary for that patient, because now all of a sudden here comes some person, I'm not even sure who this person is, and now they're taking my shirt off. What the heck's going on? It may be difficult or impossible for them to understand us, and us to understand them. We also have, you know, the same problem that comes up with patients of different national origin. Sometimes they don't speak English, or they don't speak English well. So we're presented with this barrier. So it's often worthwhile for the service, the system, to develop protocols, particularly say if you would have a large population of a certain national origin, or you know, maybe you have a school for people who are blind or deaf, to develop certain protocols that, should we have to respond, how are we going to make accommodations? So, developmentally impaired. The entire time that I was growing up, my mother worked with developmentally impaired people, both in a residential setting, kind of as a, you know, a house parent more or less, and then also in a vocational setting where, in a sheltered workshop where, they would get some structure and do some odd small jobs to help kind of offset some of the costs of their care. So the result of developmental disorders may be things that they came from birth. They may have been mentally retarded from birth. They could have suffered a traumatic brain injury or stroke at some point during their life, dementia sometimes. So if we would be maybe working in a dementia care center. Mental illness sometimes goes that far when we have people who are extreme schizophrenics. So developmental impairments generally are difficulty in learning or limited abilities to learn. They range anywhere from very mild impairment, and there are some people who you would interact with that belong in the category of developmentally impaired, that you maybe would have a very difficult time unless you were starting to ask some higher order questions to determining that they are developmentally disabled. And some of them, of course, are all the way at the severe and extreme end of the case, in which they may be bed or chair confined, and kind of to be stereotypical, I guess, the people who maybe are wearing helmets and have no control over their bodily functions. So there's a very wide gambit. Some of them are very capable of living on their own with very minimal oversight, and some of them are permanently institutionalized. So if at all possible and it's necessary, allow a caregiver or a caseworker or somebody to accompany the patient in the ambulance. There's a video on autism. Autism is just a fascinating spectrum of developmental disability. Some of these people are so incredibly intelligent, but really on a social side of things, really can't handle things outside of their own little world. Some people who live very, very normal lives with autism, while others, they really need to stay within their own little realm. Brain injured patients. Excuse me. Brain injured patients, they have impairment in their cognition, their emotions, and their behavior. Cognition being, kind of your normal thought process and your ability to think and reason. With emotions, of course, and behaviors are being fairly self-explanatory. These can be as a result of brain trauma. Some of the most heartbreaking stories that you see are people who have suffered traumatic brain injuries that had, very, very rich and very and high potential for their lives, and that gets shattered in a moment, and they end up being institutionalized forever. Encephalitis, so an inflammation around the brain, potentially a meningitis, which is those coverings of the brain. So oftentimes people with brain injuries end up with long-term healthcare needs, such as being on a ventilator. There is a facility in Omaha called the Ambassador. Ambassador is a nursing home that has a whole entire wing and unit that is for ventilator-dependent people. So, and it's full of all kinds of stories, everywhere from the littlest, tiniest infants you can see that are on ventilators that maybe, were born with an abnormality, a congenital abnormality, that don't need hospitalization but need routine, constant care, all the way up through, people that are elderly and living the rest of their days on a ventilator. IV catheters, many of them have central lines, many of them have infuser ports, may have pumps, may have feeding tubes, all kinds of things, tracheostomies. So individuals responsible for care of the patient are very well versed in the proper use of those devices. So in some cases, we're going to be called because one of those devices has issues. So if we have that arise, use the caregiver to your advantage. So, they know that piece of equipment better than you do. If it's a ventilator, for example, and the patient is not doing well on the ventilator and they think, well, this ventilator just doesn't seem to be working right, sometimes people get they get a little nervous, a little upset, and it's like, oh no, what are we going to do? The ventilator's not working. You have a ventilator in your ambulance. It's called a back valve. No, it's not exactly what that patient is used to or that patient maybe responds best to, but you can continue to ventilate that patient just squeezing the bag. You just have to be cautious the way you do it. Watch for chest rise. Set the oxygen at a similar level. Use your monitors such as your pulse oximetry and whatnot to monitor that patient's condition. You can do it just fine. In fact, for many, many years in EMS, we didn't have transport ventilators, and that's what we did. We took them off the big, huge ventilator in the house that's the size of a microwave, and then, we bagged them to their next place that they were going to. They don't always have to have all that stuff going as well. So if they have IV fluids that are running that are just simply TKO or something that's a routine maintenance thing, ask the caregiver to discontinue it. Feeding tubes. People do not have to be fed constantly. So ask them to discontinue the feeding tube until you get to the hospital. Make life easier. If it's something critical that they need it, the patient's caregiver will let you know that. But if it's something that they can go for a little bit without, great. Have them discontinue. So we're going to make sure that we treat all of our patients with respect and dignity, not just developmentally impaired. Enlist caregivers and family members. Just like when we're talking pediatrics, these people are the ones that our patient are trusting. So if they are the ones that have the patient's utmost trust, use them to your advantage, because we're strangers. If we're strangers coming into their environment, they maybe are not going to react well to us being somebody that they don't know. It helps reduce the patient's fear and anxiety. They can assist the hospital staff. In many cases, I've had to take somebody along, and you take a person that has a complex medical need into the emergency department, and nurses don't get one patient per nurse. Nurses often have to bounce from patient to patient to patient. And if that's the case, having this extra set of hands there that knows this patient, number one, can give them a great deal of history and background information on the patient. And number two, can take care of some of those minor needs. Paralysis. We have people who are paralyzed. We may have people that are paralyzed in one extremity. They're paralyzed on one side. They may be paralyzed just from the waist down, or from the nipple line down, or from the neck down. Sorry about that. People who have these paralysis, maybe as a result of an injury, maybe a stroke, maybe a neuromuscular disease. We talked about a couple of those, things like Guillain-Barré syndrome or disease, Huntington's chorea. Those sorts of things can wipe out some of the best or some of the major gross motor movements. It usually starts with fine motor movements. If it's a progressive thing, the fine motor movements, finger dexterity and tiptoes and whatnot, and then progresses a little further. So people that are paralyzed are very susceptible to pressure sores. Remember, if they're paralyzed, they probably don't have feeling as well. That's not 100%, because there are some people who do have feeling, but there are many of them that they don't have feeling, nor do they have motor function. So urinary tract infections is also, and pneumonia also, because when you are bed bound, you're not up, you're not moving, you're not generally able to move air quite as easily. urinary tract infections, almost all of them have some sort of a catheter, whether that's a Foley, which a Foley catheter goes, remember, up your urethra, or it's very possible that it could be a suprapubic catheter in which they actually will poke a hole in above the pubic area and run the catheter directly through the abdominal wall, or the pelvic wall, I guess, and into the urinary bladder, and it drains out actually from the hole that's in their upper pubic area, as opposed to out the urethra. Here's an example of actually a bariatric ambulance. That cot, it's hard to tell this, but that cot is significantly wider than your normal ambulance cot or stretcher. There's a set of ramps there, and those are designed so you can easily push the cot right up into the ambulance. Some ambulances have a winch actually built into them. One service that I've worked for had that, where you had a winch and a remote control that you hooked the winch onto a pull ring on the top of the cot, the head end of the cot, and it would just pull it right up the ramps. You help to guide it in. That cot is capable of holding up to 1,600 pounds when it's all the way down to the ground, so roughly 800 pounds when it's up high. Bariatrics is probably going to become just a bigger and bigger issue, no pun intended, for us in EMS, because that's the way that the American lifestyle is going. Is we're becoming wider and wider. So the obese patients often have very limited mobility. Some are unable to move on their own. Some will end up laying in beds for days on end, or weeks on end, or months on end. Largest patient I ever dealt with was 848 pounds. Required the fire department to disassemble the house. She had to be pulled across the lawn on a tarp, basically sliding on the grass, and then had to take all the mounts and stuff out of the bottom of the ambulance, or the floor of the ambulance, and just put the tarp up on the floor, because at the time we didn't have bariatric ambulances. So they had to tie 2 ER beds together in the emergency department to have them large enough to handle her. So, obese patients also have those comorbid factors, comorbid disease processes. It's cardiac disease, as well as strokes, hypertension are huge, and usually diabetes. So more and more services are making accommodations for bariatrics, particularly the larger paid services usually will have an ambulance that's equipped for a bariatric transport. There are some very, very large patients in the Omaha area, and they're not just in the Omaha area. I can think of several throughout northwest Iowa that over the years I've either taken care of or had heard stories of that. They're in all the communities. So obesity occurs when that caloric intake exceeds the amount of calories required to meet the body's needs. I think most people really like eating. I know that I do. I love to eat. It's very enjoyable. So when we have a caloric intake that greatly exceeds what we're burning off on a daily basis, it's stored as fat. So it's typically the result of overeating and inadequate physical activity. They may have underlying problems. There are a few people out there who do have some hormonal issues that don't allow them to burn their nutrients as efficiently as possible. Prior to having to even lift or transport an obese patient, you make sure you have appropriate assistance. Now, in most cases, a couple of healthy young male EMS providers probably can handle a 300-pounder. So you get much more above 300 pounds, though, you're really taking a chance by trying to have 2 people try to do it. And 300 is probably a bit on the high side. I generally try to use a rule of thumb as, most younger healthy EMS providers should be able to handle between 100 and 125 pounds of patient each. So, talking a patient greater than 250, it's probably a good idea to have an extra set of hands or 2. So sometimes that involves calling for fire or an additional ambulance. Sometimes it's using the people that you have at hand, just due to the nature of the incident. So don't try to be a hero and try to do it all on your own, because all you're going to end up doing is injuring yourself and potentially injuring your partner and the patient. So if you are faced with this, do not try to be the hero. Do what you got to do to make this a safe situation for everybody involved. So it's sad, but that's true. All right, so if you're unfamiliar with how to handle the patient's medical equipment, enlist the assistance of the caregiver. They know that stuff very well. They're probably spending tons and tons of time doing patient care for that person. They know that patient better than probably anyone else, and would be probably happy to provide you with some extra education or assist you in transporting that patient, because you're both there for the same reason, for the betterment and the well-being of the patient. Homeless or impoverished patients. Homeless people often are seen in public. They're in just dang near every community. They'll have little to no belongings. Chronic homelessness. You have unaccompanied individuals. They don't have to be unaccompanied. Sometimes we have entire families that are unaccompanied. They're homeless. So unaccompanied individuals with disabling conditions, continuously homeless for a year or more. Experienced 4 or more episodes of homelessness over the past 3 years. So what are some of these factors that are contributing to this? It can be things such as being in poverty. Maybe they've lost a job. Maybe they've lost their home. Victims of domestic violence. Lack of affordable housing. Substance abuse is very big. Mental illness is probably one of the largest as well. So sometimes the mental illness or the substance abuse precipitated the homelessness, and sometimes they come about after the homelessness. So many people who are homeless spend a lot of time wondering, how are they going to survive? We worry about these people, particularly in the winter, but the summer is also a big deal. Homeless shelters are almost always working near or at capacity. So they're at a much higher risk for illness and disease, as well as acts of violence. They don't have a nice, safe place to go to. Abuse and discrimination. They may be sleeping on the ground, benches, public places. They may try to create little shelters, and they can't afford to pay for necessities. So oftentimes that's why they end up at some of these homeless shelters, to try to get something to clean up a little bit, or try to get a bite of food or a good warm night's sleep. So some things to consider that homeless individuals may not have: medications, medical care. They can't afford medical care. If they can't afford somewhere to live, they don't have insurance. Utilities, clothing, nutritious foods, basic hygiene. So when you're caring for an individual that's homeless or impoverished, care for them as you would anyone else. Yes, in many cases, their hygiene is terrible, and it's going to be very difficult for you to handle having them in an enclosed space. They may be very malodorous. Try to work with these people. Make sure that the ER knows, hey, this person is homeless. Is there any social work, any resources available at that hospital? Because often the hospitals have contacts for lots of different shelters and other shelters and whatnot that I guess you can get patients at least a little hand up for at least one night or two. Try not to be judgmental and prejudiced. Many people have struggled with this for times in their lives, and they've lived in a car or they've been homeless, but they were able to overcome it and return to a fruitful life. Be aware of any of these special health care needs. Do they have access to their medications that they need? So they may have actually long-term issues that have gone unresolved. Abuse, physical abuse, psychological abuse, sexual abuse. We've kind of mentioned this kind of as we've gone through the course, that we've got child abuse is a big issue, but it's not just child abuse. It's other types. So physical abuse, of course, is that results in bodily injury. Psychological, this is the willful infliction of mental or emotional anguish through threat, humiliation, verbal or non-verbal means. Sexual abuse, this is contact of any kind that is non-consensual for competent adults and of any kind for children. Financial abuse is the illegal and improper use of an individual's money, property, resources. In many cases, this is the elderly or the dependent adult. Domestic abuse, violence is used to intimidate a partner to gain power or control. Probably one of the most forgotten about types of abuse. It's not a mandatory reporter thing per se, unless it is truly an act of violence, and then it is reported through other means, although it's not a mandatory reportable thing. Neglect, the failure of the caregiver to provide proper care to an individual for whom they are responsible. So in many cases of abuse, the abuser is not reported. There are many cases, you talk to people all the time that probably have suffered some sort of abuse throughout their life, and they maybe never bring it up. Maybe something that haunts them every day of their lives, even though they never tell you about it. If you have suspicions, remember it is your duty to report it. You are not proving anything, but it is your responsibility to observe and be aware of everything around you. Simply for the fact that we're really one of the very few people who actually get to see the environment that this patient is living in. So just being observant and factually reporting what you see, what you hear, what you notice, may be the only signals or signs that anybody ever gets that this is going on. So our goal in the abuse patient is to remove them from the environment and to report our suspicions. Okay? Even though we're angry to death and we really want to pummel somebody to death for doing what they've done or what we suspect that they've done, it is not going to fix the situation. Getting that patient out of that environment temporarily buys them some time. So that's why we have to concentrate on that. And then be observant. Be as much of an advocate for your patient as possible. So, multiple bruises as a result of child abuse. It's not typical to have some of those bruises on your lower back like that. Not even really on your butt, because there's enough padding on your butt usually that there's not much of a bruise there. Knees and elbows, that's one thing, but those are bony prominences that can easily get bumped when somebody falls down. Child abuse affects children up to 18 years of age. The abuser, most often somebody the child knows and trusts, maybe parents, grandparents, aunts, uncles, friends, neighbors. All races and socioeconomic groups are affected. Abusers tend to be male more often than female. In many cases, we're talking drug or alcohol or other substance abuse. There's usually obvious lack of concern for the child or an odd level of concern for the child. Sometimes it's over the top. Lack of concern for the specific injury or condition. Oh, it'll be okay, it'll be okay. More so than those of us that are EMS providers who often are like, if you haven't severed an arm, don't come running in the house to me. I'm an EMT. I'm not scared of that. So, sometimes as a parent, we're kind of like, it's all right. We're going to kind of wait and see. We don't go rushing to the ER simply from what we know from our professional life. But this is even in cases when the child does have something very severe, they don't have as much concern. They may blame the child for the child's injuries or condition, and they may openly criticize the child right in front of you. Behaviors to be alert to. Avoiding or pulling away from a parent or caregiver. Remember, we're the strange people. We're the people coming into this situation that are probably the strangers that the kid's been warned about stranger danger. So when they're actually a little bit scared of their parents, that's really, really some concern, point of concern. If they're weary or fearful of physical contact, you reach out to take their pulse and they quickly jerk away. Lack of normal crying or emotion consistent with the injury or the situation. Maybe if they cry, they know they're going to get hurt. Or a parent or caregiver is very evasive and does not have a story that lines up with what appears to have happened. Sign of elder abuse. Now, this in and of itself is not necessarily a sign of elder abuse. Just very easily could be a person who's fallen. But the concerning part's probably the more obviously older injury here. If we would show up and see this dried blood that's even started to flake off, and a well-defined, well-formed black eye here, that lets us know there's been some time since this incident's happened. It occurs more often probably in the patient's home, but it does occur from time to time in nursing homes and medical care facilities. Not even just to elders, but to dependent adults. Occasionally you'll hear of younger females that are, vegetative, becoming pregnant, and they were sexually abused by a caregiver. So the caregivers often are incredibly stressed in the whole situation, particularly those that are trying to take care of their mom or dad at home. They feel like they don't have support from other family members. And the adult male children caring for elderly parents are the most likely to commit elder abuse. So signs of elder abuse: changes in personality or behavior, tension between the patient and the caregiver, unexplained injuries, evidence of restraint, evidence that they've been bed confined for a very large amount of time. Caregiver refuses to let you be alone with the patient. Unexplained vaginal or anal bleeding, a malnourished appearance, severe bed sores. So you may find it difficult to maintain your composure in an abuse situation, but remember what our goal is. Our goal is to get the patient out of the environment and then to report our suspicions. That's what we're gunning for. And when we do this, that's going to be the best thing for our patients. So medical equipment, technology-dependent patients. So with advances in technology, we have more and more people that are likely to go home and try to live a semi-normal life at home. You need to be familiar with types of medical equipment that you're likely to encounter. And if you can develop relationships with the medical community that you're in, maybe if you have somebody who's coming into your hometown and they have a special device. I'll take, for example, a ventricular assist device, LVAD. There's also RVADs now, right? Ventricular assist. But these ventricular assist devices helps that patient's heart pump efficiently until that patient can get a heart transplant. Well, there's some special things that you need to know, and generally they're pretty good with the LVADs and RVADs of getting the medical providers in the community some education on how to handle should you deal with this. People who have a left ventricular assist device do not have a pulse. Yet they're up, they're walking around, they're talking, they're functional. They generally don't have a very significant blood pressure, and it's going to be very difficult to get one at all. And they have this weird contraption that comes out of their chest and sits in this little fanny pack thing, or this vest device. If their heart stops, or the patient goes unresponsive and you feel no pulse, you cannot do chest compressions on them. So they're not going to have a pulse to begin with. So if they're unresponsive, you may think, oh, well, I need to do CPR. Well, if you're able to identify that there's an LVAD, you'll know not to do CPR, because an LVAD actually pumps blood through a patient's heart hundreds of times per minute. So it's a constant pump. It's not a cyclic pump, it's a constant flow. And so that's why they don't have a pulse. But if you do chest compressions on them, you rip those hoses out of their heart and you kill them. So don't let the presence of this equipment distract you. You're still going to need to do your assessment. You're still going to need to provide this basic care for ABCs. So categorize. We typically have some airway and respiratory issues, vascular accesses, gastrointestinal, and gastrourinary devices that patients are generally under the care of. Medical oxygen. These are people who are on constant oxygenation. Usually they're on a nasal cannula. They probably also have a humidifier. That humidifier helps moisten that oxygen so it doesn't dry out their airways quite as much. They may have an oxygen concentrator at home. It's a little device. Usually it's brown or gray. It looks like an R2-D2 sort of, but it sits over, plugs into the wall, and it actually will concentrate the oxygen out of the ambient air and make it available to the patient. It's kind of noisy. They're not a high flow device. They typically don't go above about 6 liters or so, but the patients often will be on home O2 with these concentrators. Maybe the concentrator is placed centrally in the house and they have a long nasal cannula that they can walk all over. Otherwise, they may have smaller bottles, size A or size B cylinders, compared to our size D that we most commonly have as our portable oxygen. They may also have a liquid oxygen source. Liquid oxygen source is a very cold and compressed cylinder. In fact, in many cases, liquid oxygens are actually put into an orb or a round cylinder. It lasts longer. It's a much more efficient source of oxygen than is our compressed gas that we have. And if that patient's not able to receive their oxygen, they can quickly deteriorate. I can count a couple of cases in which the patient has run out of oxygen, called us for shortness of breath. They didn't realize that their oxygen stopped functioning or it came unhooked or whatever, but so they called us for shortness of breath. Even though they had this nasal cannula on, the other end wasn't hooked up to anything. And so we get there and we start talking to them, and one of the first things I do is, if they're on oxygen, tell me they're short of breath, I'll pull the cannula out of their nose and listen to it. If I don't hear any air flowing through it, I know, hey, let's go look. And a couple of times I've gone on this, and I went and I found, yeah, nothing's coming out. Hook it back up, and sure enough, their condition improves. So, liquid oxygen is a great way. It's a little bit more dangerous, but it's a great way to have a large amount of oxygen in a very small package. Apnea monitors. Most cases, these are infants that have apnea monitors for their breathing. And so when the patient ceases to breathe, it goes off and rings some bells and whistles, and everybody gets a little excited. So determine how long that alarm's been sounding prior to your arrival. It lets you know how long that patient's been apneic. We may have tracheostomies. Tracheostomy tubes. These are actually tracheostomy catheters. And in this case, it's showing us a couple of different types. We may have a very complicated type, like the one shown on the bottom there. It actually has a cuff that blows up. People would be able to talk with something similar to this. The If they block their tracheostomy, they can force air out through that fenestration, and it will then go up through the vocal cords, and they'll be able to speak. Others don't have that, so they may have to use sign language or writing. And the biggest problem that we have with people with tracheostomies is getting obstruction from mucus. Occasionally there's problems with getting an air leak, sometimes a little infection, maybe some bleeding around it. The other big issue might be dislodgement of a cannula. So knowing how these work, that shows you that inner cannula there. Usually there's an inner cannula that goes inside the tracheostomy tube itself. And that inner cannula is something that can be taken out, it can be cleaned, and then placed back in there to help keep a nice open airway. Depending on the type of tracheostomy they have, you may or may not be able to hook a bag valve mask up to it. There may be the typical adapter that you would see like on your King Airway, same size. Tracheostomies can be temporary or permanent depending on the patient. Most often, if they have a appliance there, it's referred to as a tracheostomy, and it's probably temporary. Eventually, people may develop strong enough musculature and are able to breathe well enough on their own that they will have a stoma, which is just an open hole in their throat. Oftentimes, they'll keep it covered with a bandana, but that's actually what they breathe through. Sometimes they can also cover it with their finger and talk. You may also have something called a transtracheal catheter, in which basically it's like having an IV catheter placed into their trachea that they hook oxygen up to, so they get a supplemental oxygen that way. As they breathe, it's pulled through there from the oxygen source, and they don't have any nasal cannula to deal with or masks to deal with. Chronic upper airway problems, usually on a long-term ventilator, at least at night. And typically single lumen tracheostomy tubes get used for infants simply due to their smaller diameters. So inner and outer cannulas for larger children and adults. So you have that inner cannula that gives you the ability to pull it out, clean it well, replace it. And that outer cannula basically just keeps things open. I mentioned that obstruction usually from mucus is the number one problem. Tube dislodgement is probably the second, and then occasionally some air leakage, some bleeding, or some infection. People on CPAP and BiPAP. CPAP we're familiar with from earlier in this course. BiPAP is very similar. BiPAP stands for bilevel positive airway pressure. It's basically like CPAP, except with CPAP we get the same amount of pressure the entire time, whether we're inhaling or exhaling. With BiPAP, it's one level of pressure for inhalation and a different level of pressure for exhalation. And it cycles back and forth depending on which way air is flowing, tells you how much pressure the patient will have. So this positive airway pressure is used only in spontaneously breathing patients. Patients that are not breathing on their own don't get CPAP. They get ventilated. We may use PEEP, which is a similar concept. Actually, CPAP and BiPAP are both levels of PEEP or methods of PEEP, which is positive end expiratory pressure. But PEEP gets used in people who are being ventilated, CPAP and BiPAP for people who are spontaneously breathing. Usually patients will either use a mask that covers their mouth or their mouth and nose. I'm sorry, their mouth and nose, or just that of their nose. People with COPD can benefit from home CPAP. Most common people that use CPAP are people with sleep apnea, such as myself. Patients who have mechanical ventilators. So patients who require assistance to breathe. There's tons of alarms. The biggest problem that we deal with people with ventilators is the alarms constantly going off. We can have high pressure and low pressure apnea, low FiO2. So if, say they have a pneumothorax and it's becoming a tension pneumothorax, and it causes there to be higher pressures for the ventilator to push against because there's more pressure within the chest. You may get a high pressure alarm. Low pressure alarm typically comes when you have something's disconnected. Apnea alarm, when the patient stops breathing on their own. Low FiO2 alarm, you've run out of oxygen source. Vascular access devices. This is an example. You see a PICC, peripherally inserted central catheter, usually found in the antecubital fossa. Most other central lines are placed in the chest, whether it's a Hickman or a Broviac or a Mediport, which is an implanted under the skin port for fluid and medication administration. You may have things also down in the inguinal area, such as a femoral catheter. Most commonly, they're either in the arm, up underneath the shoulder, or the upper chest. It's where you most commonly will see those. So these are readily available devices for when people have constant intravenous medication, constantly getting blood draws. Usually if the medication is very hard on their veins, they will consider putting a vascular access device in. Many chemotherapies are really tough on patients' veins, and so those people will usually end up with vascular access devices. People who get long-term antibiotic care, something like an osteomyelitis, which is an infection of the bone marrow cavity. If you have that infection, you're going to be on IV antibiotics for months. You'll probably end up with a vascular access device. People who getting hemodialysis also have these. This just keeps from having to poke veins constantly, because veins will eventually develop scar tissue, and it makes them more brittle, makes them less easy to establish IVs on. So some of the central lines placed in very large veins use subclavian vein, maybe be in the superior vena cava. Some of them, like the PICC, are usually into the brachial vein, or the major large veins of the upper arm that feed back to the subclavian and then the vena cava. And then the implanted vascular venous access ports. Back in the when we were talking IVs, there was a PowerPoint that had a number of these in that section. So I think that would be actually in chapter 1 or week 1. That there was a PowerPoint that had a number of these demonstrated and at least illustrated for you there. So the access ports are planted underneath the skin. It's just like the top of a vial of medication. So there's a rubber membrane in the middle of it. There's kind of a hard ring around the outside of it. You can puncture directly through the middle of it and do your vascular access that way. Dialysis shunts. Patients who receive hemodialysis will often have these put in. Usually they're in their forearm. An AV shunt, AV fistula, AV graft, where they've connected an artery and a vein together. Took the middleman, the capillaries, out of it, and it's a place that they access, put blood in and take blood out. Controlling bleeding to any of these areas is going to be via direct pressure. High flow oxygen as necessary, treating for shock. Sometimes people will cut these different devices and end up having pretty radical bleeds going on. Feeding tubes. Here's an example of a surgically inserted feeding tube. Goes right through the abdominal wall, right into the gastrointestinal tract. Loss of GI or GU function, they're going to rely on different devices either to receive nutrition and water or to eliminate it. So we may have feeding tubes, we may have ostomy bags such as a colostomy where they've opened up the colon to the outside and they poop in a bag. Urinary tract devices, whether they have a suprapubic catheter, a Foley catheter, you may even have something that's called a urostomy where they actually take tubes and put them right into the kidneys themselves and drain the urine directly from the kidneys, so they don't even have to run down the ureters. Feeding tubes. G tubes go right into the stomach. J tubes go right into the jejunum, which is a section of the small intestine. So people who may not be able to chew, swallow, maintain their good, strong airway, they often will end up with G tubes or J tubes. We may have NG or OG tubes, and when we have NG or OG tubes, we maybe have a patient who just hasn't gotten far enough through the system yet to receive a G or J tube. NG, nasogastric through the nose, orogastric through the mouth. There's the G and J tube, like I mentioned. So when we're talking G and J tubes, we're often talking people who are probably long-term tube feeds. Ostomy bags. This allows them to collect feces from the patient's colon, maybe because they've had diverticulitis, colon cancer, Crohn's disease. Sometimes it's temporary, sometimes it's permanent. A lot of times it's temporary. They've been treated for colon cancer. They will get a colostomy for a couple of weeks, months, what have you. Then they'll go back and they'll, after the bowel is healed, hook it back together and allow them to continue to function normally. Here's an example of a condom cath or an external cath. Sometimes it's called a Texas catheter. I call it a party catheter. If you never had to leave what you were doing because you could just pee right in the bag there. So it reminds me of an episode of Big Bang Theory in which Howard Wolowitz is sitting at the movies with a little bag attached to his calf that he was sitting in line at movies and peeing in. So these often will get used in a short-term basis just to collect urine while a patient maybe is temporarily unable to get out of bed. Here's how an internal catheter or Foley actually works. So this tube goes up the external urethral meatus, or goes up the urethral meatus, goes into the urinary bladder, and once the tip is in the urinary bladder, they will inflate the balloon on the end of it with some saline, and that helps to anchor it in the urinary bladder and keeps it from just falling out, slipping out. So this is a gravity-dependent system. The bag needs to be lower than the patient's bladder. So oftentimes when we pick up patients to move from place to place, they have a Foley, we may put that bag up on their lap just until we get them into the ambulance. And then we really need to take that bag and put it on the floor so it allows the urine to drain. Otherwise, the urine is retained and backs up, and it can back up into their kidneys, causing some problems. So, talked about urinary catheters and condom catheters. Foley. Okay. UTIs. Again, I can't emphasize this enough. People with indwelling urinary catheters are routinely victims of either UTI or of urinary sepsis. This is an intraventricular shunt. We talked about this in the pediatrics chapter where we had patients who developed hydrocephaly, or water on the brain. Basically, they create a lot of CSF, a lot of cerebrospinal fluid, but yet don't lose what they've already made. They don't drain it. So this is an artificial drain that's put in. It drains actually out of a couple of the hollower areas of the brain and allows you to pull off that extra pressure. Doesn't allow pressure to build up because it drains and it just dumps into their abdomen. And when it dumps into their abdomen, their body then will reabsorb it from there. But there's room for it in the abdomen. There's no room for it in the hard casing of the cranium. A couple problems. Occasionally, these will become clogged. And most of them actually, the biggest problem in kids is kids outgrow them. And so the tip no longer is residing within whatever it was intended to drain into, and it kind of gets overgrown, and then it can't drain, and the patient ends up building up extra pressure and has a seizure. So, placed, like I said, most of the time into the abdomen, occasionally into the heart, the pleural space, the blood vessels in the neck. Infection, occlusion can be big issues. Occasionally subdural bleeding, that's not very common. Would be more common soon after receiving it. So when called to care for or transport patients with a ventriculostomy shunt, it may be necessary to transport the patient to a medical facility where neurosurgical services are available. I think it's a good case, or a good point to be made, is when you go and pick up these patients with special medical needs, you may need to be a little flexible in your transport options, because transporting a lot of these patients to the local hospital that may be 10 or 15 minutes closer, you're not going to do them any justice, because that local small town hospital maybe doesn't have any services to help this person, and they're going to end up transferring them anyway. That all depends on your system and where you're set up at, whether you do interfacility transports or another service does. Hospice. Hospice care. This is comfort care for terminally ill patients. So it's usually geared towards pain management, usually a little rehydration, keep the patient hydrated, and it provides the patient and family with support. It's really designed to help the patient die with dignity in a comfortable setting and allow the family and the patient to start the grieving process. So, people in hospice generally are have this terminal illness. Means it's an illness that they're not going to recover from. Hospice evaluates the patient on a regular basis, so there will be regular reassessments to make sure that the patient still fits the need. Most people are on hospice for a matter of days to weeks. Occasionally you will have people that are on very long-term hospice. One of the big things with hospice care is occasionally the patient has a turn for the worse and there's not hospice staff around. The family gets excited and they call 911 and we show up, and it's actually time for the patient to expire, but then the patient's family says, no, we want you to do everything. Hospice does a very good job of trying to educate the family to not do this, but occasionally it happens. All right, so you'll encounter patients with special challenges that range from hearing disabilities to homelessness to using medical technology at home. You need to understand their needs, how their challenges relate to you, and the reason that you were called. Always remain a patient advocate. Avoid temptation to give your feelings in a stressful situation. Do not allow the presence of the equipment to distract you. Caregivers are extremely helpful in many cases. Sometimes they are kind of a pain in the butt, but in most cases they're very helpful when it comes to us assisting us in providing care for their loved one or their patient.